you very much. My name's Todd, as Courtney said. I'm an anaesthetics and intensive care trainee with an interest in how to manage exertional heat illness, specifically severe exertional heat illness, which is exertional heat stroke. We've collaborated as a kind of a multi-agency group to develop some strategies about how to manage and effectively cool people who get hot. And these are some of the organisations that have been involved in that process. A key stakeholder are the military, and as Courtney said, we've translated some of the military best practice into civilian populations, and we'll be using those strategies tomorrow at the London Marathon. So to begin with, I've got no declarations. Very happy for you to take photos of the slides, but there are some slides of direct patient care. They'll have a little picture of a camera with across through it. Please don't take photos of those. They're just for sharing within this room. I'm going to go through the diagnosis of exertional heat illness, how we classify it, why we should be worried about it, specifically, what's the incidence, why it happens, the associated pathophysiology, and then how do we operationalise a treatment strategy at mass participation sporting events. So I'm sure you've all seen these photos, this series of photos before. So this is Johnny Brownlee, the 2016 Triathlon World Championship final, and he's collapsing over the line, having been leading until about 150 metres to go. He started wobbling all over the road. Alistair caught up with him and helped him cross the line. And at the time, I think, as was shown with that clip of Callum Hawkins, the commentators were talking about dehydration, exhaustion, not really picking up on the fact that this is almost certainly heat illness. And heat illness is classified into kind of heat exhaustion, which is a milder form of heat illness, moderate heat illness, and then severe heat illness. And severe heat illness is synonymous with heat stroke, and I'll be talking about exertional heat stroke for the purposes of this talk. And the classification for exertional heat stroke is a core temperature of above 40 degrees Celsius, but as Lee showed, that's not necessarily associated with pathology and can be a normal response to exerting yourself to a high level. So importantly, exertional heat stroke isn't just a high temperature, it's also signs of end organ dysfunction. And the end organ dysfunction that's most obviously manifested is CNS dysfunction, okay? Because we can't look inside a person and see how their kidneys, their heart, their liver is coping with the effects of the heat, but we can see how the brain is responding to that high level of heat. And so if we see brain dysfunction, central nervous system dysfunction, then we're saying that this patient has severe hypothermic illness, and that's defined as exertional heat stroke. So I want to talk quickly about a case that happened a couple of years ago, because I think this highlights why we need to be worried about it and also some of the associated challenges. So this is in a military setting. This is a soldier called Sapper Connor Morrison, and he was a soldier in the 23rd Parachute Engineers Regiment. He had recently passed out of basic training. He had joined his unit a couple of days before, and they had planned to go for, I think it was a 10k run in July in Suffolk, at an army barracks in Suffolk. And about 8k into that run, he collapsed. Initially, he was seen to be struggling on the run. He was motivated by his peers, encouraged to carry on. They managed to get him running again, and then unfortunately, he collapsed a few minutes later. And he never regained consciousness, and he died a couple of days later. And following that case, there was a couple of inquiries. There was a coroner's inquiry, and then there was a Defence Safety Authority inquiry. And the Defence Safety Authority inquiry really drilled into the details of his care. And although exertional heat stroke was suspected a few minutes after he collapsed, even though it was a relatively cool day, it was only about 17 degrees Celsius, the soldiers had a lot of training on this illness. It's obviously been an issue in the military before with deaths on the Brecon Beacons. So it was suspected, but adequate cooling didn't happen for over 40 minutes. Okay? So he was left in a hypothermic state for a prolonged period of time, and ultimately we think that contributed to him developing multi-organ failure and unfortunately passing away a couple of days later. And as part of the learning from that experience, the military has invested a lot of time and energy into improving their already pretty good standards of care around exertional heat illness, and we want to try and translate that learning into a civilian population. So how worried do we need to be about exertional heat stroke in a civilian population? So there's a really good registry from Paris, which it has about 46 races in it. It's about over 1 million competitors included. And they've seen exertional heat stroke or severe exertional heat stroke about 11 times in 1 million cases. They've seen about 36 life-threatening events, and 11 of those were heat-related. The rest, 25, were related to acute cardiac events. So it's rare, but it does happen, okay? And what this doesn't quantify is people we perhaps have associated morbidity from an episode of heat stroke who get discharged from the medical tent, who go home and then have a period of being unwell or might develop deferred problems down the line. At Brighton, we audited the patients who were treated for collapse in 2021, and we found that about 6 of those out of the 34 had an elevated core temperature of 40 degrees Celsius, giving an incidence of around 3 in 1,000. But we then did some subsequent studies at Brighton the following year and discovered that, as Lee has demonstrated, that a lot of runners do get hot anyway, and they're asymptomatic, and that's not a pathological condition. So you've got this challenge of trying to understand, one, is someone being hot a problem? And I think we can quickly clarify that with the presence or absence of CNS dysfunction. But also then, how worried do we need to be about this patient having CNS dysfunction and being hot? And what does that mean in terms of short and medium-term morbidity? So there's a really good case series or a systematic review that's been done by the Doug Kasser American group, and this was a systematic review performed in 2020, so pretty big data set. Obviously there'll be a few more cases that have occurred since then. And they essentially identified 521 cases of exertional heat stroke in the literature, and demonstrated that of those 521 cases reported in the literature, there was a mortality of 23, okay, which is about 4%. But what that doesn't tell us is about morbidity. So they might have survived, but what was that survival process like? Did that involve any critical illness? Again, we can look at some specific races. So this is the Falmouth race in America. It's a race in Massachusetts. It's held in August. It's run in the morning generally, but obviously it's typically quite warm. It's 7 miles, and they see a pretty high incidence of exertional heat illness, with around 20 to 30 of the 10,000 runners treated for exertional heat illness. They have developed, given the relatively high incidence, very effective cooling methods for exertional heat illness. They have a big bank of tubs full of ice-cold water that they put their runners into to try and rapidly cool patients down to what we consider a safe temperature of below 39 degrees Celsius. Typically, patients spend about 15 minutes in the tub after presenting with a temperature of, say, 41.5, it takes about 15 minutes to get them cool. And they've demonstrated that with effective cooling, a relatively small proportion of those patients, around 10% of those patients, need ongoing medical care. So they're not able to be discharged from the medical tent and they go into hospital. But again, this data doesn't tell us about subsequent morbidity. So it doesn't tell us about what happens to these patients when they get to hospital and how ill they are. And this is something we're interested in because our experience at Brighton and also looking at the data in London shows that some of these patients who get hot go on to develop critical illness and have an extended period of care on the intensive care units. They might develop end organ failure, including renal failure, requiring renal replacement therapy, and some of them go on to need liver transplants. The amount of patients, and this is borne out in this data set. So this is a really nice data set that Dr. Ross Hemingway has produced. So he's called a lot of Marines at the Commando Training Centre in Devon. The Marines obviously have an incredibly arduous training programme that includes a lot of endurance exercise, and it's performed throughout the year, and often, given the highly motivated nature of the recruits, they see candidates pushing themselves very hard, and they see relatively high rates of exertional heat illness. And I'll talk about how they deal with that a bit later on. But what they do find, because they're able to follow these patients up really closely, which often we don't have the benefit of in mass participation medical care. We're not able to, follow up these patients once they've left the medical tent, is they see significant levels of biochemical derangement. So all of these 35 patients, Marines, made a good recovery, but at day 1, day 2, day 3, there were significantly elevated levels associated with an acute kidney injury and also an acute liver injury. Okay, so even patients who seem well have a degree of biochemical derangement that suggests they've had significant end organ damage as a result of their episode of exertional heat stroke. One of the things we do worry about is the effect on the liver. The liver is very vulnerable to temperature, and that's for a couple of reasons. One, the cells themselves are susceptible to hypothermic damage, but also we know when you get hot, your gut becomes more permeable, and so bacteria that sits in the gut normally, happily there, doesn't leave the lumen of the gut, is able to translocate, so move from the gut lumen into the bloodstream, and the first organ the blood will flow to, following having left the gut, is into the liver, and so the gut can be the liver can be a victim for kind of direct bacterial damage as a result of that gut permeability associated with exertional heat stroke. And this case series in France showed 24 patients developed exertional heat stroke over about a 20-year period. So small numbers, but it does happen, and 4 of these needed a liver transplant, and 2 of those died. Okay, so acute liver failure as a result of an episode of exertional heat stroke is definitely a thing, and definitely something we need to be worried about. And as our duty of care that Prof. Kipps mentioned to runners, we need to try and limit the chance of them developing end organ failure or significant end organ failure as a consequence of exertional heat stroke. So the pathophysiology of exertional heat stroke is complex. I don't think it's not well understood, but I think there's probably 2 components to it, or 3 components. So the first is the direct hypothermic cytotoxic effects. So cells aren't meant to be hot as 41 degrees Celsius, which is a core temperature we commonly see in patients with exertional heat stroke. And so that heat load can cause direct cellular damage. Then there's the element of the bacterial translocation. So we know that as you get hot, blood is shunted away from the gut, and that makes the gut more permeable, and so bacteria can leave the gut lumen and get into the bloodstream, and that can cause a bacteremic effect. So you have pathogenic bacteria in the bloodstream, and that can cause a picture similar to sepsis. And then we know also that some patients have a susceptibility to a very inflammatory response to heat, and that's similar to the phenomenon that we see in infection. When patients get a bacterial infection, the magnitude, the severity of how unwell there isn't necessarily related to the specific bacteria that they're infected with. It's the host response, it's their immune system's response to that bacterial infection that can often drive the syndrome of sepsis and systemic inflammation that then causes the patient to become increasingly unwell. And I think we see that in heat as well. So some patients will get a heat load, and they will have a much more significant systemic inflammatory response to that heat load. The relationship of heat to mortality and morbidity has been well demonstrated in animal models. So this is in a rat model, and you can see here that patients, rats even, who are hotter for longer and or have a higher magnitude of heat exposure are more likely to die. Okay, so that ties in with the kind of the theory that an element of this is how hot the cells are getting, and there's the longer you are hot for and the hotter you are hot for is associated with greater end organ damage and end organ destruction, and ultimately potential end stage organ failure. There's an interesting link between some other conditions and exertional heat stroke. So there's a condition that we see in anaesthetics called malignant hypothermia. And this is a genetic disease where you have a abnormality in some of the intracellular receptors that influence how much calcium goes in and out of muscles. And in patients with malignant hypothermia, they have a defect where a general anaesthetic will cause them to have a massive influx of calcium into their muscle cells, and this will cause muscle destruction and very high levels of muscle metabolism and can ultimately lead to death. And there's been some interesting studies that have shown patients who have malignant hypothermia share some upregulated gene expression with patients who have had an episode of exertional heat stroke. So what I'm trying to say here is that there's definitely environmental factors, there's definitely factors related to kind of that increase the susceptibility of patients to exertional heat stroke, but there's probably also some underlying genetic mechanisms that are underpinning this. So not every person who gets exertional heat stroke will develop critical illness, but unfortunately, we're not able to predict that in advance, and so we need to aggressively treat everybody who presents with exertional heat stroke and try and limit their time under the curve of having a very high temperature. So how are we going to treat this? I think a really good analogy for treating exertional heat stroke is the chain of survival. That has been demonstrated to be highly effective in patients who go into cardiac arrest. So this is a very well-established paradigm in patients who have a cardiac arrest, and it's all about early recognition, early treatment, chest compressions, and then early definitive treatment, defibrillation if they're in a rhythm that will respond to defibrillation, and then really high-quality acute follow-up care. And I think we can apply those principles to our management of exertional heat stroke. So we need to minimise the risk of a patient developing exertional heat stroke, and a lot of that is using the strategies that Lee has talked about. Early recognition, so anybody involved in the management of patients at a mass participation sporting event needs to be aware of the potential that an unwell patient might have exertional heat stroke and take early measures to get help to them quickly and also start the cooling process early. Very aggressive cooling of these casualties, because we're not able to differentiate which ones are going to be the ones that get worse and potentially go on to develop severe organ dysfunction. And then also follow these patients up carefully, because there are patients who have gone home from the medical tent with a relatively innocuous, apparently innocuous episode of exertional heat stroke, who have then gone on to develop end organ failure 2 or 3 days down the line and needed liver transplants, having been at home for a day or two, getting worse. Whether or not we could have changed the trajectory of that with better follow-up is hard to say, but we certainly need to know about these patients and make sure they're followed up appropriately. So how are we going to achieve that? So first and foremost, runner education. Runners are, the participants are key stakeholders in this process. We need to make them aware of the risks and make them aware of the things they can do to mitigate and minimise their risk, particularly around issues around acclimatisation. You can get acclimatisation benefits very quickly within 7 days of starting an acclimation programme, and that part of the reason why we see relatively high levels at Brighton and London is because I think a lot of these runners won't have had any acclimation because it's been a cold, wet spring, and then suddenly it's a hot day. And we had a very sick patient at Brighton, despite it not being that hot, but I think a key component of them developing it was slightly hotter than previous days, so they just weren't used to thermoregulating at a slightly higher environmental temperature. And then we also need to think about the events, and as professionals working in this space, we need to think about how we can mitigate the risk and the characteristics of the event specifically. I think we're pretty good at doing that, maybe there's work to be done with smaller numbers of events, but certainly in the past there were events, especially on the continent in America, where the race was starting at midday, just as the peak temperature was starting to get there. So one of the things we can do, this is a quick shout out to Dr. Bolch, who's one of the organisers. So she's developing a patient education website, Race Ready. It's available as an app on your phone, and this has a load of really useful information about how you can prepare for events, and it includes mitigation strategies for exertional heat stroke. I think as race organisers, they have responsibilities, however they do it, to get this information pushed and available to patients so they can inform themselves and take that responsibility for mitigating strategies as best they can. Early recognition, so I think a key stakeholder in this is the volunteers at races. Unlikely that a patient is going to collapse in front of a medical professional, and so it's about making sure that everyone else involved in the race is aware that someone who collapses is likely to have exertional heat stroke, and start early simple first aid measures, so calling for help and starting to cool them down, get them into shade, fanning them, dousing them in water. Early recognition, this is a challenge because these patients won't necessarily have a raised tympanic, so eardrum or infrared temperature. So the non-invasive ways we have to measure temperature in patients just don't work in exertional heat stroke, because these patients are often peripherally shut down, so that their periphery is cold and their core is roaring hot, and so if you're trying to measure the temperature peripherally, you're just not going to get an accurate reading of what their core temperature is doing. So we need to have lots of capacity to measure core temperatures, and that's a rectal temperature, okay? So however events do that, they need to ensure that first aiders are able to, get access to a core temperature as quickly as possible. Aggressive cooling, so this is kind of where the work we're doing comes in, and what we've developed at the London and Brighton marathons with translational work from the Marines. So these are some of the cooling strategies that you can employ. So the best is ice cold water immersion. So this is where you stick a patient in a tub of ice cold water, and you really rely on the conductive cooling properties that confers. Second best is probably strip fan spray, but you have to aggressively fan the patients, almost have an industrial fan in front of them, and then use the evaporative processes that Lee spoke about. That will only work if you're also spraying them, because these patients don't sweat due to the nature of their heat illness pathology. So you need to be covering them in water and then aggressively fanning it off and getting phase change heat loss in that way. And then there's less effective cooling methods, such as putting ice towels over the patients, putting hands and feet into tubs of cold water, because you've got some anastomosis between the arterial and the venous systems in your hands and feet that can be very good at exchanging heat. But none of these are as good as ice cold water immersion. But to be fair, it's better than nothing. So whatever your strategy is, you need to do it, and whatever your capability is, you need to ensure that you do it as well as you can, okay? And then importantly, we want to start cooling very early on. So the classic paradigm of how to resuscitate a critically ill patient is to think about their airway, think about their breathing, think about their circulation, think about disability, all those other things. But we know that time is tissue in heat illness, similar to other pathologies, and so we need to start cooling as quickly as we can. Importantly, these runners might have been hot for a while before they decompensate and collapse, so that hypothermic effect might have been going on for a while, and they might have already been experiencing significant cell injury and end organ injury. So as soon as we can, we need to start cooling, and we need to start cooling aggressively, and we need to change how we manage these patients so that we're cooling them as we deliver those other life-saving interventions. Other things to think about in collapsed athletes is glucose. So there's always a chance patients have low glucose. This is actually more relevant in hot patients, because when you're hot, your body's unable to make glucose. So often we find these patients have a low glucose. It's rarely life-threateningly low, but it's definitely something we want to treat. Sodium's less of an issue now. So if we went back 20 years ago, we saw lots of low sodiums, hyponatremia. But due to better patient education and change in our advice about drinking to thirst and not over-hydrating, we see less hyponatremia now, but it's definitely something we want to exclude. We didn't see any cases at Brighton this year, but it still could happen, and it's something we need to measure and think about. Cardiac's important. You saw in the Paris registry that 25 out of the 36 patients who had a life-threatening event had a cardiac event. So that's definitely something we need to think about. But arguably, a hot patient having a cardiac event, the heat is going to exacerbate the severity of that cardiac event. So there's potentially we can treat both concurrently, but we need to have a think about that, and you need to have a protocol that acknowledges that a collapsed athlete might have an acute cardiac event, and we need to screen for that and incorporate that into the management if they're also hot. So how do we do that? So this is tricky, because exertional heat stroke, by definition, they're going to have CNS dysfunction, and often they can be very obtunded. So it's not uncommon to see a GCS of 3 to 7. So these patients are moribund, they're not responsive to painful stimulus, they're not opening their eyes, they're not obeying commands. And so it's very difficult potentially to cool them and deliver that life-saving intervention they need. What this graph does show is that as you cool them, they typically wake up. So this is a case study from Brighton. He presented, this was a runner who presented with a core temperature of 42 degrees Celsius. It was cold last year at Brighton. This isn't necessarily a disease of hot weather, but for whatever reason, his body had become increasingly hypothermic, and those thermoregulatory mechanisms had failed, and he collapsed at the finish line with a GCS of 10, which is essentially deeply unconscious. So but he woke up quickly as we cooled him. But how are we going to cool someone effectively when they're deeply unconscious? So Previous techniques, methods that have been used around the world are ice-cold water immersion, but this is what is happening in this chap in this tub. But obviously that's difficult if they're deeply unconscious. You've got other methods that might be more appropriate if they're unconscious, such as ice towels, fanning, but we know they're not as effective. So what we've developed is using a pod, okay? So it looks a bit like a body bag, unfortunately. That we put the patients into, and then we fill up the bag with ice-cold water. The advantage of using a pod is it's very portable, and also it allows us to rapidly safely evacuate the patient from the pod if they do deteriorate and we weren't able to safely maintain their airway. This device is called the iQuick. It's been developed by Dr. Ross Hemingway, who had a lot of experience of cooling Marines at the Commando Training Centre, and he was using a different product, but he found that it leaked, it wasn't quite as effective as he wanted it to be, and so he's developed his own version. So this is developed and made in the UK, this iQuick. So the way we use it, these aren't great photos, I'm sorry, but essentially the patient is retrieved by a retrieval team. They're brought into the triage area, the heat illness triage area. Our criteria for being triaged is they've got a depressed conscious level, so confused, and that might even be mild. So they come in, we're suspecting they might be hypothermic. They're rapidly assessed in about 60 seconds, and part of that assessment is that they have a core temperature measured rectally, and then a probe is inserted as well, allowing continuous temperature monitoring. And then the bag is then zipped up and filled with ice-cold water. It's obviously quite labour intensive because you've got a critically unwell casualty here who potentially has a compromised airway. So at the head end, you typically will have an anaesthetist or someone with a similar skill set who's able to manage the airway and make sure that they're happy that the patient is ventilating and not obstructing their airway. And then you've got a team around them who are delivering those other resuscitative interventions and managing the airway, the breathing, the circulation, thinking about the glucose, thinking about the sodium. But our priority is cooling them as quickly as we can. And we can achieve very high cooling rates with this technique, as high as 0.3 degrees Celsius per minute. So if you think a patient typically will present with a temperature of around 42 degrees Celsius, and we know that above 40 there's probably cell death occurring, you can potentially get them out of that danger zone within 8 minutes and down to a more acceptable temperature. This can be delivered in the field. So this is Ross out on the Devon Moors, Dartmoor. So obviously his military recruits, commandos, they'll collapse, mid-session, not necessarily at a medical centre. And so he's developed a mobile strategy to call at scene and then transfer first. And for anyone who works in the NHS, you know that our capacity to call in a busy A&E department is very limited, if non-existent. So it's really important that pre-hospital providers take the responsibility for cooling at scene and making sure that we deliver the casualties who are normothermic, who then need ongoing care and follow-up. So acute follow-up is really important for the reasons I said. You can develop delayed organ dysfunction. That is urine on the right-hand side, and that's something called myoglobinuria. So as part of the process of exertional heat stroke, you get muscle breakdown, you get release of proteins from those muscles into the blood, and they're directly toxic to the kidneys, and you can develop significant kidney failure for a period of time. And there's plenty of cases, some that I've been involved in, where patients have needed intensive care and renal replacement therapy for several days whilst their kidneys recover from this big load of toxic proteins that's been released during exertional heat stroke. The other thing is the liver, and we need to do serial tests of liver function to make sure they're not developing liver failure. Acute follow-up is a big component of that, as well as kind of the medical follow-up, is patient advice. So these patients will be heat intolerant for a period of time, and it's really important they don't do anything to raise their core temperature, including exercise. They need to take it really easy for 2 weeks, no exercise, and then a gradual phased return to exercise. And we see that patients who try and return to exercise too quickly are heat intolerant, and essentially their thermoregulatory processes have failed. And they're not able to monitor, they're not able to modulate their heat as they exercise, and so they're prone to a second episode of exertional heat stroke. And unfortunately, some people who have an episode of severe exertional heat stroke never return to activity. Their thermoregulatory processes are compromised forever, and they're not, so there's plenty of cases of Marines who haven't been able to go back to their unit because of an episode of exertional heat stroke. So just to reiterate, exertional heat stroke, it's often fine, but sometimes it's not, and we can't tell that when the patient first presents to us. So we need to try and mitigate it happening, minimise the risk of it happening. We need to recognise it early and start aggressive cooling as early as we can, and we need to follow these patients up to make sure they don't have any kind of short-term organ dysfunction or damage associated with that episode of exertional heat stroke. They're my references. Thank you very much.